Hello, everybody. I'm really happy, and I have a great pleasure to join this webinar. Webinar in these tough days, which we all hope that we will pass all safely from it. And I think, as we see the world around us, that the life should go on until this pandemic goes away. I think that the presentation of atherosclerosis 2020 is one of the important topics which came to the stage in the last year, and I like to title it Atherosclerosis 2020 Between Prevention and Intervention. And actually, in 2015, there were an inspiring statement by Professor Valentine Foster, who stated that transition from cardiovascular disease to health by using the subclinical disease at basic and clinical and population level. Really, this statement has a great future prospect. As you see here from the coming slide, that the concept was changed of coronary artery disease from lesion-focused to patient-centered. And all through this journey, we have a lot of important stations to push the journey from coronary revascularization to early detection of the cardiovascular disease for the hope of prevention. Started 1980 by coronary artery stenosis as a focus of detection and treatment, as we all know, by using the PTCA, then using the stents for dilating the coronary stenosis. Then an important station came, which is the vulnerable plaque assessment, to know at what time this vulnerable plaque will rupture and to give the proper management strategy to prevent this vulnerable plaque from rupture and causing the cardiovascular event. Then it will pass through the myocardial ischemia focus for detection and treatment with several modalities and drugs for treatment of symptoms and also the outcome. And then in recent years, the very important station, which is the concept of inflammation as a key factor for disease activity and risk. Then we came to the vulnerable patient concept, and then to the assessment, physiologic assessment of the lesion by using the FFR and using the FFR-driven treatment. Then we jump to the clinical and subclinical atherosclerotic disease burden as a determinant of the adverse outcome, and also the prothrombotic milieu for atheroma burden and disease activity as a triangle of acute coronary syndrome risk, and to in a hop of to reach the early detection and prevention. With the invention in the last years of a lot of imaging modalities, we can detect the vulnerability, and we can assess the plaque to put the patient in the proper risk category for proper management. As by using the IVUS, we can detect the magnitude of the necrotic core. Also, we can also know the thickness of the cap, because as we all know, we have two types of plaques, those with thick cap and those which are more vulnerable are those with thin cap. Also, we can detect the areas of calcification, as you can appreciate here in these IVUS images as a white patches. We can see how much the calcification are. It is mild, moderate, or heavy calcification, and I think this not only guide the interventional management, but can also guide the risk stratification of the patient for the management strategy. Not only by using the IVUS, but also by using the OCT, optimal coherence tomography, we can deeply dive through the plaque to assess more the vulnerability of the plaque. to assess more the necrotic core, to assess more the thickness of the cap, because as we all know, if it is more than 170 micron, it is considered by OCT a thick cap, and if it is less than 65, it should be considered as thin cap, which should be considered as a vulnerable plaque. Also, if we dive more, we can see that sometimes there is an areas of microchannels, which means new vascularization inside the plaque. And also we can assess the rupture or the rupture of the cap of the plaque to assess more the vulnerability of the plaque and its potentiality for developing cardiovascular events. Not only the vulnerability, but we can assess also the healed plaque, because as we all know, the atherosclerotic coronary artery plaques are prone to rupture, prone to erosion, and with repeated episodes of non-occlusive thrombosis due to rupturing or erosion, it passes through the healed coronary plaque stage, which can be assessed by the optical coherence tomography. So not only the vulnerability, but also the stability of the plaque can be assessed by the OCT. Again, there is another modality which came up to the stage, which is the CT. By using the CT also, we can assess the areas of low attenuation, which means the lipid core, the areas of high attenuation, which indicates the fibrosis, and also we can indicate the areas of fibrosis inside the plaque by using the CT. But sometimes not only the calcium distribution is important, but also the calcium density. And by the new modalities in the CT, we can use some tools to assess the calcium density inside the vascular wall. And the calcium density is proved to be as much as more important than the calcium volume for the detecting the calcium or the calcification in the plaque. Sometimes we need to use a combined modalities for imaging, for detection, and for assessing the plaques. And if you look to this picture, you can appreciate here, this is an MRI. An MRI without using PET, and on the left panel, an MRI with using PET scan. An MRI in the right panel, we can see here that the ascending and descending aorta, it seems to be normal without any detection of plaques or potential risk plaques. By using the combination of PET imaging, it proved to be there is an inflammation inside the wall of the ascending and descending aorta, which means that the hidden plaque there is a vulnerable plaques to develop an event. Again, here in the carotid, by using the CT, when combined the CT with PET scan, we can here again confine and define the vulnerability of the plaque and the potentiality of the plaque to be risky by using the combined CT and PET scan. Through the journey of the from 1918 to 2020, there is a very important station, which is an inflammation station. And the NLPR3 inflammation has now been identified as a cross-link between inflammation and cholesterol metabolism in atherosclerosis. And as we all know, there is a very important landmark trial, which is the CANTOS trial, which is using the caniconamab, which is targeting the interleukin-1 beta, which is responsible for transforming to interleukin 6, which take its circle in the liver to give us a marker of high sensitive CRP as a marker of inflammation, which act upon the atherosclerotic lesion to develop the event. So from CANTOS, we have an evidence for the importance of the inflammation, and we have another evidence for the use of the caniconamab to counteract this inflammatory process and the cross-link between inflammation and the cholesterol metabolism. Actually, it is not one factor, it's multifactorial influence of the anatomic stenosis we see by the angiography, for example, by the plaque characteristics as we see by IVUS or OCT, and finally, the physiologic stenosis severity as we can assess by the FFR. By combining all those modalities, we will better assess not only the lesion, but also the patient. We will detect the vulnerable plaque and also the vulnerable patients. We will detect the high-risk plaque characteristics, which is important for risk categorizing the patient, and those patients, plaques with minimal human area less than 4 millimeter square, or plaque burden more than 70%, or low attenuating plaques by CT, positive remodeling by CT, napkin ring sign by CT, and spotty calcifications by all imaging modalities we have. Let's go through a very important arm for detecting the patient risk, which is the risk scoring. All the European societies concerning with cardiovascular disease and also the American are using the score charts or the risk score assessment for atherosclerotic cardiovascular disease. For example, this chart, which is color-coded by dark red, light red, yellow, and green, we can appreciate here the importance of the age. And if we look at here, we can appreciate that the risk of this 40-year-old male with smoking as a risk factor is same as the patient with 65-year-old man with ideal factor levels. So we can appreciate here the patient with 40 years with risk factors is as risky as patient with 65 years without risk factors. And this is the importance of putting every patient over 40 in a risk score chart, which including the smoking status, the systolic blood pressure, and the total cholesterol. A very important sector came to the stage in the latest guideline, which is the risk enhancing factor for clinician-patient risk discussion. And as Professor Ashraf declared in his very elegant presentation, which is the genes, we can take from it the clinical part, which is the family history of premature atherosclerotic cardiovascular disease. Already this is a reflection from the genes. The premature atherosclerotic cardiovascular disease, which is male below 55 or female below 65 years. Also, the primary hypercholesteremia is considered as a risk enhancer. The metabolic syndrome, with its components, which is the triglycerides above 150, elevated blood pressure, elevated glucose, and also the increased waist circumference. Not only those, but also the chronic kidney disease with eGFR between 15 and 59, and also the chronic inflammatory conditions. Those risk-enhancing factors came up from history and came up from some laboratory workup. Some of the risk-enhancing factor also, which we sometimes missed from history even, the history of premature menopause before age of 40, and the history of pregnancy-associated condition like preeclampsia. Sometimes we have high-risk ethnicity like those with South Asians. And the elevated high-sensitivity C-reactive proteins, if done, can be considered as a risk enhancer. Elevated lipoprotein little a above than 50 milligram per deciliter. And the forgotten lab marker in the lipid profile, which is the elevated ApoB above 130. Also, we have some of the risk enhancers, special risk enhancers in the diabetic, which is the duration. And it is very important to know the duration of diabetes, especially for those with type 2 diabetes more than 10 years and for type 1 diabetes more than 20 years. Albuminuria more than 30 micro, eGFR less than 60 in diabetics. Retinopathy in diabetics is also one of the risk enhancers. Neuropathy is also one of the risk enhancers, and we have a lot of patients who are suffering from neuropathy. We can consider it as one of the risk enhancers in diabetics. API, ankle brachial index less than 0.9. And that's why, because of the imaging modalities we see, because of the patient-centered approach through the journey of atherosclerotic cardiovascular disease, the new recommendation came up in 2000 at the end of 2019, which highlighting the importance of cardiovascular imaging for assessment of atherosclerotic cardiovascular disease risk and assessment of arterial plaque burden on arterial ultrasound should be considered a risk modifier, especially in those patients in the blind spot. The patient in the blind spot are those patients with low or moderate risk. Are those patients asymptomatic with low or moderate risk? those patients are living in the blind spot, and we have to light up the light to uncover them and to put a proper management for them. Also, the cardiovascular imaging, by assessing the calcium, is came up to the stage for those patients asymptomatic with low or moderate risk. I think this slide is passed away by Professor Ashraf, but I'd like to highlight one thing. And one of the top evidences which came in the guidelines is that the target for those patients was very high risk. The evidence that we have to go down 55 milligram per deciliter and more than 50% reduction from baseline. For those very high risk, this is one of the new indications for those patients with proved atherosclerotic cardiovascular disease, or those patients who have an acute coronary syndrome events or cardiovascular events. Now we came to the take-home messages, and I think the most important take-home messages came up from the American Heart Association, American College of Cardiology. They stated a 10 top take-home messages. The most important way to prevent atherosclerotic vascular disease is the prevention of heart failure and atrial fibrillation, is to promote a healthy lifestyle throughout life. And I'd like to highlight here that it should be throughout life, not only in a period of time, not only after an event, but it should be throughout life. Number two, a take-home message is a team-based care approach. We have to work in a team work approach by the cardiologist, the endocrinologist, diabetologist, and sometimes the dietitian for proper management of patient. Number three, adults who are 40 to 75 years of age and being evaluated for cardiovascular disease prevention should pass through a score chart. In addition, we have to add the risk enhancing factor, especially for those patients who are low or moderate risk. And sometimes those patients are missed in the clinical practice. So we have to use the new modalities for imaging like coronary calcium scanning to uncover those patients, especially those patients above 40 years of age. Number five, which is now very important to be stated, that the healthy diet. The healthy diet is now pushed up by every cardiologist, by every internist, to counteract the cardiovascular disease by using vegetables, fruits, nuts, whole grains, and lean vegetables, and to be away from trans fat or refined carbohydrate and sweetened beverages, and to be motivated for weight loss if they are obese. It's also a very important take-home message. Number five, the adult should be engaged in at least 150 minutes per week for accumulated moderate intensity physical activity. And I'd like to highlight here, it might be 75-minute week if some of them are doing a vigorous intensity physical activity like playing tennis. Some of the patients can playing tennis, so it is enough for 75 minutes per week for vigorous intensity physical activity. For those patients with diabetes, it goes without discussion the importance of lifestyle changes and achieving exercise. But now, after adding metformin as a first line of treatment, now we have a new kid which come on the block, is the sodium glucose transporter inhibitor. If we failed to reach an euglycemic pattern for the diabetic patients by metformin, we can add SGLT2 inhibitors or GLP-1 agonists for those patients, not only for controlling diabetes, but also for cardiovascular outcome. Number seven, all adults should be assessed at every healthcare visit for tobacco quit. Every patient should be motivated in every visit for tobacco quit, and not let the patient make you quit advising him before you advise him to quit. Number eight, which also one of the important evidence which came to the stage in the latest evidences, is the role of aspirin in the primary prevention. And as we all see from the ASCENT trial, there is a lack of net benefit for using aspirin, especially for those patients with low or moderate risk for atherosclerotic cardiovascular disease. Number 9, statin therapy is a first line for treatment for primary prevention, especially for those patients with LDL above 190 and those with diabetes mellitus who are diabetic for more than 10 years of age, and those determinant to be sufficient atherosclerotic cardiovascular disease, and especially if we do it after a clinician patient risk discussion. We have to have a discussion between the patient and the physician as regard his level of risk. Why? Not to underestimate the risk of the patient, not to overestimate the risk of the patient, not to undertreat the patient, or not to give the patient unwanted medication. Number 10, non-pharmacologic intervention is the first step for treating hypertension. Then if we fail, we give up the medication, aiming for the target of blood pressure, which should be less than 130/80, but not below 120/70. And finally, atherosclerosis 2020, between prevention and intervention. I'd like to be back again to the very inspiring statement by Valentine Foster, which is the transition from cardiovascular disease to health. It will be up when we are applying a prompt prevention, prompt preventive measures, and using the suitable imaging and therapeutic intervention to counteract this major problem, which is atherosclerosis. And thank you for your attention.
Thank you, Professor Sayed, for your elegant lecture. And I have a question for you. When to discuss risk-enhancing factors with our patients?
This is a very important question. As I mentioned in my presentation, we have a sector of patients which are lying in the blind spot. The blind spot is those asymptomatic patients who has low or moderate risk. Those patients may pass their way without any intervention, I mean without any medical intervention or any preventive intervention. By using the risk enhancers, either by taking a good history or by diving through some of the lab workup, we can uncover the risk and we can put them in the proper risk category, and also we can treat them properly. Those patients from low to moderate risk, I think we can use heavily the risk enhancing factor to assess the patient properly.
I have a question from the audience. Is there a link between inflammation and vascular calcification, Professor Sayed?
Again, actually, this is an important question. And the playmaker here for the calcification and inflammation is the lipid oxidation. The lipid oxidation actually is the playmaker, which leads to pro-osteogenic mediators such as the minimally modified low-density lipoprotein and oxidized phospholipids, which leads to both the atherosclerosis and also the vascular calcification. So the lipid oxidation is the playmaker in the inflammation for developing vascular calcification.
I have another question, Professor Sayed. Is there a decision-making approach to selective use of coronary heart disease calcium measurement for risk prediction?
Oh, yes, it is a good question also. Here, we have to use, or we have to back again to the 10-year atherosclerotic cardiovascular risk calculator. Why? Because if we know the actual risk of the patients, which is lying between 5 and 20%, those patients are really in need. Those patients below 5, no need for do calcium score. And those patients actually go without saying that those patients above 20, they need also calcium scoring. But those patients from 5 to 20, actually we need to do calcium scoring, because by doing calcium scoring, we can reclassify the patient either up or down. We can retreat the patient either up or down according to the calcium score in this midway area from 5 to 20%. And this gives us the importance of doing an atherosclerotic cardiovascular risk score for patients above 40.
I have a question for Professor Ashraf Reda from the audience. To what extent lifestyle interventions can neutralize the genetic risk?
Lifestyle intervention is very important, whether in reducing the risk on clinical basis or even in neutralizing some of the atherogenic risk alleles in our body. If you exercise daily, if you control your diet and control your weight, by the end of the day, you will reduce a little bit your LDL cholesterol, you will reduce your blood pressures, and you reduce your weight. This actually neutralize the risk alleles that responsible for the mechanism of atherosclerosis based on these risk items that I mentioned. So actually, diet and exercise can neutralize about 15 risk alleles based on 164 risk alleles study. And this is, as I explained in my presentation, is very, very important and can change the risk category of a patient and can affect the future event in a beneficial way. It's really amazing to know that some exercise and stop smoking and reducing the weight can neutralize some genetic risk factors and can decrease your genetic risk score.
Thank you, Professor Ashraf Reda. Thank you, Professor Syed Farag, for your presentations, for answering the questions and the discussion. And thanks for the audience hearing us and watching us. And now I lead the lead for Professor Ashraf.
So thank you, Dr. Atif. Thank you, Dr. Syed. And I think by the end of this webinar, I have to special thanks to the ICOM company, Hazem and Yusri and Marianne. Also, thank you to Pfizer company for the non-restricted educational grant. And of course, before that and after that, thank you for the participating audience and looking forward to see you in future webinars and event of IAVA. Thank you very much.